Hi, I'm a rheumatologist and I'm going to teach you how to treat ANCA vasculitis. 3 things guide your treatment plan: the severity of disease, the organ involvement, and the type of ANCA vasculitis. Every treatment plan involves 2 phases: remission induction, which is getting the fire out, and remission maintenance, which is keeping that fire out. Severe disease means organ or life-threatening disease. So think rapidly progressive glomerulonephritis, diffuse alveolar hemorrhage, vision-threatening scleritis, nerve damage, etc. Non-severe means things like joint pain, mild sinus disease, mild skin disease. The key question is there imminent risk of irreversible organ damage? Severe disease requires more aggressive interventions like IV steroids, rituximab, cyclophosphamide, and we do not delay treatment waiting for the biopsy in people who are rapidly deteriorating. There are 5 interventions that are typically used in severe ANCA vasculitis, and I'm going to explain each of them with an analogy so you will understand the mechanism of action. In ANCA vasculitis, the immune system produces rogue antibodies, the ANCA antibodies, that activate the neutrophils inappropriately and cause them to attack the body. Think of it like a false alarm sending soldiers into a frenzy and attacking the walls of their own city. These active neutrophils will release toxic chemicals. They will release sticky webs called nets or neutrophil extracellular traps. And they trigger the complement system, which is like an alarm system that triggers a cascade that recruits even more soldiers. This results in something like a self-perpetuating riot. Each medication targets a different part of this riot. Steroids are like a massive fire extinguisher. They calm down everything broadly. So they dampen the entire inflammatory cascade. They suppress cytokine production and reduce neutrophil activation. They cool everything down quickly, but they do not address the underlying cause. They are essential early on, but can cause many side effects with prolonged use, like infections, osteoporosis, etc. B cells are the immune cells that produce the ANCA antibodies, which are the false alarms that call more soldiers to come and join the riot. Rituximab is a monoclonal antibody that targets CD20 on the B cells and destroys them. Without B cells, the factory that produces ANCA drops dramatically and ANCA levels will decrease significantly. Rituximab spares the long-lived plasma cells that make protective antibodies like from childhood vaccines. Think of it as demolishing the factory that is making defective weapons while leaving the factory that is making useful tools intact. Cyclophosphamide is an alkylating agent, so it cross-links DNA, essentially gluing the 2 DNA strands together so the cell cannot divide and function. It kills rapidly dividing cells, including B cells and T cells. Unlike rituximab's targeted approach, cyclophosphamide is more like carpet bombing and hitting everything all at once. It suppresses the entire immune system, wiping out rogue cells, but it can also cause a lot of collateral damage. It increases the risk of cancer, infertility, infections, and bladder toxicity. Plasma exchange physically removes the ANCA antibodies and other circulating inflammatory mediators from the blood and replacing it with donor plasma or albumin. It's like vacuuming up those false alarm signals from the streets. It works fast, but is temporary, and if you don't use other therapeutic interventions, then the body will just keep producing more ANCAs. During the riot, activated neutrophils will trigger the complement system. This produces a molecule called C5a, which is essentially like a megaphone screaming, "Send more soldiers." This creates a vicious cycle. Avacopan works by blocking C5a, so essentially blocking that megaphone and stopping this cycle without broadly immunosuppressing. Every major randomized controlled trial on remission induction in severe ANCA vasculitis uses glucocorticoids along with rituximab or cyclophosphamide. Remember that pulse steroids are like a massive fire extinguisher, so we use IV methylprednisolone between 1 to 3 grams, and then we follow with oral prednisone 1 milligram per kilogram per day, and then you taper down gradually. This serves as a bridge therapy because rituximab and cyclophosphamide have a delayed onset of immunosuppressive action. Steroids work within hours to days, and rituximab and cyclophosphamide can take weeks to months to translate into meaningful clinical remission. So whenever the medical meme accounts make fun of rheumatology saying we only know how to use steroids, it's most likely because they've only ever been exposed to inpatient rheumatology and you have not had time to see how our medications work or to understand the real effect. CD19 is a protein on B cells that we check to track the response to rituximab, and it usually gets to undetectable levels by day 15. Clinical remission takes longer because ANCA antibodies are also produced by short-lived plasma cells that are CD20 negative. So ANCA titers typically decline by about 48% per month during induction. Cyclophosphamide is a prodrug, meaning it has to be processed by the liver in order for it to become active, and this can take several hours. B cells and T cells die off over days to weeks, and white blood cell count will typically hit its nadir about 2 weeks after the first infusion. Clinical improvement can take weeks to months. The RAVE trial found that rituximab is equivalent in efficacy to cyclophosphamide and is actually better in a certain subset of patients. Rituximab is the preferred option if the patient is PR3 ANCA positive, if fertility is a concern, if they have had multiple rounds of cyclophosphamide in the past, and if this was a relapse. Cyclophosphamide holds its place in severe kidney disease, like with creatinine greater than 4, just because of a lack of prospective data on rituximab, and in patients for whom access to rituximab is limited due to cost. With regard to plasma exchange, the PEXIVAS trial showed that PLEX did not reduce death or kidney failure, but later analyses did show that it may help kidney function recover faster in the first few weeks. So current guidelines say it is reasonable to consider in severe cases like people with diffuse alveolar hemorrhage or those with severe kidney failure requiring dialysis. A few years ago, avacopan came onto the market as a steroid-sparing option for severe ANCA vasculitis, and it looked extremely promising. The study showed comparable remission rates, better sustained remission at 1 year, and dramatically less steroid use. However, in June 2026, the New England Journal of Medicine formally retracted this study. Endpoint assessments for 9 patients were reportedly re-adjudicated after the database was locked and unblinded, and this was not reported in the initial publication. The FDA has proposed withdrawing avacopan's approval. To be clear, this does not mean that the drug is definitively ineffective. It just means that the evidence base under it needs to be re-examined. Once remission is achieved, everybody goes on maintenance therapy. We taper steroids as quickly as we can. After rituximab induction, the goal is to be completely off steroids by the end of 6 months. After Cytoxan induction, the goal is to be down to 5 milligrams per day by the end of 6 months. Rituximab is preferred for remission maintenance, with azathioprine being the primary alternative if rituximab cannot be used for whatever reason. Guidelines favor fixed 500 milligrams of rituximab every 6 months. Alternatively, rituximab can be dosed based on the reappearance of the CD19 B cells or ANCA levels, which leads to less overall rituximab exposure, and one trial did show that this was equivalent to fixed dosing. The optimal duration of treatment is between 18 months to 4 years. Longer maintenance does tend to decrease relapse rates and kidney failure incidence. EULAR recommends 24 to 48 months of maintenance. Certain factors that favor longer duration of therapy are diagnosis of GPA, relapses, and PR3 positivity. It is recommended to start PCP prophylaxis in all patients on rituximab and Cytoxan, as it significantly decreases the risk of infections. KDIGO recommends checking immunoglobulins at baseline and then every 6 months while on rituximab. They recommend immunoglobulin supplementation if IgG is less than 3 and the patient is having recurrent infections. I hope this was helpful. If you did think it was, please drop me a comment, hit that like button, and subscribe.